I think there is this, I think, misconception that all LHRH agonists are the same. And you use one, you use the other, it doesn't really make any difference. And I think for most community practices, the decision about what LHRH agonist to give is really based upon cost, trying to limit the number of choices, not trying to let each individual physician choose their own. From a business model standpoint, it's just easier to say, we're only going to offer this particular brand. Some of the companies have better monitoring schemes for inventory, those types of things. But getting back to, again, this concept that potentially this Atrigel system may actually have some benefit in having lower levels of testosterone. How does that play into your thinking in terms of, is that enough of a, is there enough evidence there that you believe that may actually be a superior product, whether we're talking about biochemical recurrence or clearly in the metastatic castration-resistant prostate cancer patient?
Well, I think we discussed earlier about, we know the duration of action is probably longer than in the 7.5 milligram dose. So we know it potentially lasts longer. And so if a patient accidentally misses an appointment, you still get good coverage and their testosterone are still castrate. But I think Neil Shore is going to present some data here pretty soon that's also going to show when they looked at their 7.5, the 1 month, the 3 month, the 4 month, and the 6 month, that they were able to achieve castration, again, less than 20 in 90%, or even higher, maybe 92% of the patients across the board. And I think that differs from Garizolin. I think that differs for just leuprolide acetate, where maybe 70% in some of their older data. Now, again, it's not a fair comparison because it's not a head-to-head trial. It's more just the trial from Eligard. And again, from a practical standpoint, in a community urology practice, we have to make sure inventory-wise how we purchase the product, number one. Number two, we also have to look at safety, efficacy, and whether we're going to achieve what we want scientifically. And then the most important aspect is how we're able to make sure that our medical assistants aren't given the drug before it's time. And so each of these companies have developed a monitoring system to make sure that we don't infuse a drug before. Otherwise, we are stuck with the cost of the product.
What about sub-Q versus IM?
Again, I think the IM is tolerated a little bit better. You would think it'd be the other way, but there is a significant amount of site reaction with the Eligard. They do develop a little knot, a little redness. It's in my estimations, very minimal, but if when you look at it across the scale, it's probably less tolerated than the IM injection.
Okay. I think it's interesting when you look at all the data in terms of how this developed going back to Shalley back in the 80s, is that, and even some of Mark Garnick's early data, is that everything is based on 28 days, but yet the reimbursement scheme, you can't give it before 30 days, and so again these again very subtle, these sustained levels, lower levels for a prolonged period. Is it going to make a difference? Potentially. Is it enough to, again, drive your clinical decision-making?
Again, I think Ash discussed, we don't really know the data on microsurges and what are the outcomes. Again, in my gut, I think that it probably makes a difference if you can keep them castrate at 20 continuously versus having them escape that level, and I think that makes a huge difference.
And I was actually surprised when I saw the Eligard data early on that they've always shown that they have continuous lower levels of testosterone, less than 20, even less than 10, right, versus your traditional leuprolide acetate.